This is Unit 8, alterations in endocrine and metabolic function. It's basically diabetes type 1 and then growth hormone deficiency. So there is a review of the endocrine system if you really have no clue what the endocrine system is or does. I would recommend you look at it. It's 862 to 865 in your new book. If you feel like you at least have a grasp on it, then you're okay. So first we're going to go over diabetes mellitus. It is a chronic metabolic disorder. And so as we talked about in class, most children have type 1, which is insulin-dependent diabetes. So they basically have no to little production of insulin, and so they need insulin because their body's not producing it. However, we have seen a humongous increase in type 2 diabetes with children, and because of the obesity epidemic, and I've even seen a 3-year-old diagnosed with diabetes type 2, so it is out there and is happening, and you probably will deal with patients regardless of if you're in the pediatric population or not that have had type 2 since they were children. All right, so you can just read this slide. You don't have to memorize it. You're not going to be tested on it. All right, so for causes, it's definitely an autoimmune disease. We're not 100% sure what causes it, but again, it's definitely an autoimmune disease. That is like the #1 cause. And then there's also a genetic component. So basically what studies have deducted so far is that your body is exposed to some kind of virus and an autoimmune response takes place. And so then your body produces antibodies, and these antibodies attack the beta cells in your pancreas. And remember, the beta cells produce insulin. And so while those beta cells are being attacked, they aren't producing insulin, and those beta cells are dying and they don't come back. And so then you have type 1 diabetes because you don't have enough beta cells in your pancreas and you are now insulin dependent. So that's a little bit about the pathophysiology and then the cause. The onset is rapid, which is different than gradual with type 2. Obviously, you're going to have the 3 Ps, the polyuria, the polydipsia, polyphagia, and then you're probably going to have weight loss and dehydration at the beginning. So obviously, insulin secretion decreases secondary to the damage in the pancreatic cells, which causes your blood sugar to increase, which means there's decreased sugar in the cells. And then once that renal threshold for glucose is exceeded, which is, I think, 180 in children, they're going to spill the sugar in the urine, which is where you get ketones and sugar. And so fluid follows sugar, and that's where you get the polyuria and the dehydration. And the liver starts metabolizing fatty acids, and the breakdown byproduct is ketones, again, where you get those ketones. And so they end up in metabolic acidosis or metabolic ketoacidosis or DK. Hopefully you'll get them before they're in DKA. But a lot of times they're spilling ketones in their urine once it's discovered that they have type 1 diabetes. And that's just done by urinalysis or urine dipstick or UA. All right, so clinical manifestations: abdominal pain, vomiting. They might have bedwetting because of the polyuria. They're going to be tired. Adolescent girls may have vaginitis because there's increased sugar in that area. And so yeast likes to grow on that increased sugar warm area. Again, classic symptoms, the 3 Ps. You don't have to memorize the glucose levels, but just know them. Medical management is basically your #1 is going to give insulin because they aren't getting enough insulin. And so you're also going to do dietary management is also important in type 1, not just type 2. You're going to want to make sure that they're exercising, and then psychosocial support. Insulin replacement is a primary treatment. You're either going to do sub-Q or they're going to have an insulin pump. Most children today are placed on insulin pumps because it's easier. It checks your blood sugar for you. It masks your body better. Most children today are not giving themselves injections like everybody was 40 years ago. My dad still gives himself injections, but I think he's one of the few people that still does it. Oral medications, you're not going to see really in type 1. You're only going to see it in type 2. So, insulin. You should know the onset peak and duration for Lispro. Hint, hint for the test. You should know these. You should know, be able to recognize regular and NPH, but definitely know Lispro. When you think about insulin, they're giving these children, like I just said, are giving themselves several sub-Q injections in one day, or they have an insulin pump. You also should think about Lantus, which is long-acting. This is important that it can't be given with another insulin. It just is one shot at a time. It cannot be mixed with the other ones. Typically, it's given at bedtime, just to give a slow, steady release overnight. It is a sub-Q injection. You're typically giving Lantus once a day, and then you're giving the short-acting insulin a couple times a day, usually with meals. There is no peak, and it lasts up to about 24 hours. I have seen, like in my grandmother, she actually splits up the Lantus between how much she gives at night and then how she gives half at night and half in the morning. Most children just give it at night one time, but if they have issues with bottoming out, that's one way you can deal with that. So insulin is usually given, you know this, given before breakfast, dinner, and bedtime. This is also going to be individualized, so they're going to need a lot of support, and it's based on their child's disease. You're going to check their blood sugar, obviously, before meals, and you're really aiming for 80 to 150. That has changed. When I was in school, it used to be 60 to 100, but they've upped it because 60 is pretty low and 80 to 150 is fine. And then a bedtime snack is important because you don't want them to bottom out overnight, like I just talked about with the Lantus. So they really need that bedtime snack. Technically, insurance only covers, and I hate how insurance dictates everything we do, but insurance only covers a 23-hour admission for a new diabetic. So really that teaching and practice time starts at the admission. So you want, you know, the old nursing saying, see one, do one, teach one. You really want the parents to watch your first injection in the child and watch everything you're doing so that within 23 hours they can do it on their own at home. They're going to check an A1C. You don't need to memorize the normal values. Do know, though, that an A1C measures the average daily blood sugar for the previous 8 to 12 weeks, so about 3 to 4 months. And again, 80 to 150 is where we want to see it. Typical meal plan for diabetic, you want 50% carbohydrates and complex carbohydrates, 10 to 20% from proteins, 30% from fats. 3 meals a day with 2 snacks is pretty routine. It's actually more closer to 3 with that bedtime snack. And then consistent eating times are essential. It's important to think about the developmental ages in pediatrics, so it's easy, to get a well, it's not as easy, but like getting a toddler to eat at the same time may be difficult, or getting a middle schooler to eat at the same time or eat at all may be difficult. And then certainly with teenagers, when they like to stay up late and then they like to get up late and they're not on a regular scheduled period, then it's certainly difficult with teenagers managing this disease. I will never forget this teenager who regularly came into the ER in DKA. I mean, she would have neuro symptoms, but she would come in DKA because she just didn't want to take her insulin, and she was rebelling against her disease, which is what teenagers do. And so not only are you managing the disease and everything that goes along with that, but in pediatrics, you're also managing their developmental levels, and it's a lot of psychosocial management here. Okay, back to dietary management. I got off on a tangent there. Increase fiber, which we should all do, decrease cholesterol, increase unsaturated fats. So good fats decrease serum lipid levels. They still need milk because they're still growing. Type 2 child, however, you want to limit their calories to decrease that weight and maybe get rid of that diabetes altogether. All right, so exercise regimen is important because they're children and they're going to want to play, regardless of if they're on a team sport or anything like that. They're still going to want to run around outside and play. So regular exercise is good. It assists with the blood glucose control, so you won't have to give as many interventions. Their insulin requirements will be decreased, so they won't need as much insulin. We do recommend that they eat a snack before they exercise, so about half an hour before, and that's about 15 to 30 grams for each 45 minutes to an hour of exercise. So if you know they're going to go practice soccer for an hour and then play an hour-long soccer game, you're going to want to give 30 to 60 grams of carbs about 30 minutes before. So before you get in the car to take them to soccer. Because they can become extremely hypoglycemic with that. All right, complications. Basically, their blood sugar is either too low or too high. So hypoglycemia, they've either had too much insulin, too little glucose, they've had excessive exercise, which we just talked about, they've missed or delayed a meal, which we talked about with teenagers, how that can be hard, or their blood glucose is less than 70. So there is quite a range of symptoms for hypoglycemia. And it can go anywhere from just clammy skin to neuro symptoms. You guys can read them to yourselves. You probably memorized or learned, hopefully, these in your adult classes. They're going to have that shaky feeling. They're going to have a headache. They may be confused. They may be sleepy. They may be dizzy. With hypoglycemia, they will have the normal breath odor. They aren't going to have that fruity breath like they will in hyperglycemia. So medical management for hypoglycemia, you're going to check that blood glucose. If you think they're acting like sleepy or confused, you're going to check their blood sugar. If it's low, you're going to give them glucose immediately. So you're going to want to give something that's high in sugar, like orange juice or cake frosting or something like that. For my grandmother recently, she's not really, you guys know she's on hospice, but she isn't really eating much, and so she is a diabetic and her sugar tends to drop a lot. So they have these actual liquid things now that you can give, and it's so much better than the paste or those glucose tabs, because those are so chalky and stuff like that, and they're hard for her to chew. So they have this liquid that is the same amount as 4 of those glucose tabs, which we recommend that you give 3 glucose tabs if they're low. So there are lots of options out there. But the most important thing is that you want to follow that by a carb-containing snack, because if you just give that sugar high, then they're going to crash. But if you give them the sugar and the carb together, then they're going to maintain the higher blood sugar, and they won't rebound. All right, so DKA is another complication of diabetes. You can go into a diabetic coma with DKA. I talked about that teenager earlier. It's a type of metabolic acidosis. Your blood glucose is usually greater than 200, and so your pH is low and your bicarb is low. And these kids are definitely going to go into the PICU because they are either not making enough insulin, or they've had too much sugar, or it's a combination of both. It can also be caused by excessive stress or illness. So we would, a lot of times, if there was a GI bug going around, we would see diabetics come in DKA because they became so dehydrated and couldn't hold any food down or anything like that. And so since they weren't eating, they weren't giving them any insulin, and anyways, it was just a spiral. But excessive stress or an illness can cause DKA. An excessive intake of food, like a bunch of birthday cake, can put you into DKA. Again, you're going to have polyuria, polydipsia, nausea and vomiting, abdominal pain. You're going to have thirst. You're going to have Q-small respirations, which if you've never seen them, you won't forget them after you've seen them once. They may have chest pain. They may have an altered mental state, depending on how bad it is. They are going to have flushed skin. They may be weak, and then again, they're going to have that fruity breath. And so how you manage it, again, they're going to go into the ICU. And you want to go ahead and bring those blood sugars down slowly, because if you bring them down too fast, you can actually put them at a risk for cerebral edema. So they're at risk for cerebral edema because of the DKA, but then also if you bring it down too fast, they're at risk for cerebral edema. So it's kind of a catch-22. You don't need to memorize the formula. Know that when they're in the ICU, their blood sugar is going to be checked hourly, and you don't want it to drop too quickly. And then once you do get their sugar to 200 to 300, you're going to go ahead and add some sugar to that IV. So you're going to add dextrose to go ahead and bring them down even slower. And then you're going to give them IV hydration. So to correct that acidosis, you're going to give them potassium, bicarb, and we just talked about dextrose. You may give them some Q insulin. We talked a little bit about the insulin pump already, but I just want to retouch on that. You know, it mirrors the body's natural release of insulin, and so most people start out on the insulin pump now. I will add a little nursing tidbit on insulin pumps. You want to make sure if they come into the hospital or are admitted to your floor or transferred to your floor from somewhere else and have an insulin pump, that the insulin pump is not currently in their body, because we have done that. We have done that before in the ER, and it was obviously a huge mistake. But, you know, they come in DKA and we give them this huge amount of fluids and fluid bolus, and so that's dropping their insulin or dropping their blood sugar. And come to find out, their insulin pump was never disconnected, and so they're dropping even more because they're getting that insulin. So if they have an insulin pump, just make sure that it is disconnected if you don't want it to be connected. I also want to talk about sick day rules really quick. This is important. So obviously if they're sick, we talked about this earlier, there's going to be an increase in the blood sugar. So you're going to want to monitor those blood sugar levels more often. You are going to want to dip all of the urines for the ketones to see if they're spilling ketones, because if they are, that's typically when they need to go to the hospital. So every time they pee, you're going to dip that urine at home. And the parents are taught, or the patient is taught, how to dip and look for ketones. You don't want to stop or skip the insulin doses if they're sick, and then you want to be sure to encourage PO fluids to encourage hydration. So that's it for diabetes type 1, and now we're briefly going to go over growth hormone deficiency, which is what it sounds. So you're not your body isn't producing or secreting enough growth hormone, so you're going to have poor growth and short stature. So your skeletal growth is affected, as well as your metabolism is affected. The causes you can read yourself. Most of the causes are unknown, but you can read these yourself. So basically, growth slows or stops with growth hormone deficiency. However, they are born normally. So they are born at a normal weight and a normal height at birth, and then they slow or stop growth. And how this is discovered is ding, ding, ding on those growth charts that we had you plot out. And if you have children and your pediatrician isn't plotting their growth on a chart, you may want to ask them, or you could do it yourself, I guess, but you may want to ask them to go ahead and chart their growth to make sure that they are growing accurate or well enough, and that they're still within their percentile. There are a bunch of tests that you can do. One is they're going to have a delayed bone age, and how they do that is they test the wrist for it. And so they will actually x-ray the wrist. And so say you have a child who's 5 years old, and you think they're at risk for growth hormone deficiency, and you x-ray the wrist, their wrist may actually only have an age of like 18 months. So that's how they would determine that, or one of the ways. Clinical manifestations, again, they're going to be small. They're not going to be very tall. They may have hypoglycemia. They may have increased fat in the trunk area. They may have a high-pitched voice. They're certainly going to have delayed puberty. They may have a micropenis or undistended testicles for males. Diagnosis, we've already covered this, but you're going to plot it on a standardized growth chart, which is hopefully how they catch it at first. You can do the bone x-ray, and there are a ton of endocrine blood tests that they do, but you don't need to know those. You won't be tested on those. How do you fix it? Well, they aren't making growth hormones, so you're going to give them growth hormone. Protropin is the one that they typically use. I wouldn't worry about the Nutropin, but the Protropin, basically you're going to be given that. It says 6 to 7, but most of the time you're going to be given it 7 times a week. It is a sub-Q injection, and you continue it until those growth plates close or until the desired height is achieved. It is very expensive, so you're going to continue it until adolescenthood. And then, think about, it's either the patient or the parents that are giving these injections every night. And so that's going to be important in your patient education and family education. So nursing management, which is the most important, you want to speak, we talked about this in class, but you want to speak to a child in an age-appropriate manner because they often look younger than they actually are. Another thing you might want to do is have stools in the house. Like if they can't, you know, you see this a lot of times with younger kids, but if you have a smaller kid, you still may want to have a stool under the kitchen sink so they can wash their hands and see the mirror. You may want to have stools in the doctor's office so they can hop up on that stretcher and not be embarrassed to ask to be picked up. Stuff like that, just to give them their independence and not rely on others. Again, teach parents how to mix the medication and administer it. Like I said, you are typically giving it at night because that's the body's natural time to secrete it. And then teach the parents the side effects of the growth hormone. And side effects include nausea, vomiting, and abdominal pain. You want to rotate those sites so you don't develop too much scar tissue. The big side effects, they are at risk for cerebral edema. So anything that involves the neurosystem, so headache, blurry vision, anything like that, you would obviously not want to give those sub-Q injections and take them to the ER. They're also at risk for hip or knee pain or a slipped femoral capital head. Slipped femur capital head. And that's all I have for nursing management. And that's all I have for Unit 8. If you have any questions, please let me know.